So good evening, dear doctors. Welcome to the panel discussion. Today we are going to discuss about the holistic management of IBS constipation and chronic constipation. So there will be a brief introduction and context setting by me. I am Dr. Bushra Hassan Khan, working as a senior regional medical advisor at Dr. Reddy's, based out of Delhi. Then holistic management of IBS constipation and chronic constipation will be taken up by Dr. Umesh Goel, followed by a panel discussion. So we have esteemed gastroenterologists with us today in the panel discussion, Dr. Umesh Goel, Dr. Manjeet Goel, Dr. Rajdeep Singh, Dr. Bhupender Singh, and Dr. Prerna Goel. This will be followed by a conclusion given by Dr. Umesh Goel. So in brief about the speaker as well as the panelists. So Dr. Umesh Goel is a consultant at Dayanand Medical College and Hospital, Ludhiana. So he's a governing council member of the Indian Neurogastromotility Association. He is selected to represent India on the esteemed Rome Partners Education Committee, Rome Foundation, USA. He has an experience of more than 18 years with more than 70 publications and 8 chapters in various books. He also has given 61 oral or poster presentations at various conferences. He is an editorial board member and peer reviewer for various international and national journals. He is also a recipient of multiple awards, including the National Scholar Award at the United European Gastro Week, and he has conducted various clinical trials as principal investigator. Welcome to the panel discussion, Sir Goel. Then we have got Dr. Manjeet Goel as a panelist. So he's an accomplished IBD expert with extensive experience in managing complex IBD cases. He is having gained international exposure through his research endeavors at University of Michigan. He blends American academic rigor with the Indian clinical excellence. He was given Best of the American College of Gastroenterology poster award for 2 consecutive years. He was awarded International Travel Grant by Government of India for presentation at ACG in 2022. And he is also inducted as laureate by Curious Journal. Welcome to the panel discussion, Dr. Goel. Then we also have Dr. Rajdeep Singh, who is a consultant gastroenterologist at JP Medical Center, Chandigarh. He has more than 17 years of experience with him. His areas of interest are endoscopy, IBD, and IBS. He has various fellowships under his name, and he also has presented various posters at various conferences and is a faculty at various national and international conferences and CME. We also have Dr. Bhupender Singh. He has more than 13 years of experience. He is a consultant gastroenterologist and interventional endoscopist at Amar Hospital, Patiala. His key areas of interest are hepatology and therapeutic endoscopy. Now, we have Dr. Prerna Goel with us. She is a senior consultant at RG Stone and Super Specialty Hospital at Ludhiana. So she also has various accolades to her name, like Fellowship of the Indian Association of Clinical Medicine at Annual Conference 2022 at Rajgir, and then Servier Research Award at Vishakhapatnam. Prajwalika Scholarship Holder Year in 2022, 2023, and 24 under the aegis of WinCares. She is an additional medical superintendent, RG Stone and Super Specialty Hospital, Ludhiana. She is also an executive editor, section Allied Sciences, Indian Journal of Cardiovascular Diseases in Women, and a NABH certified assessor by the Quality Council of India. So welcome all the panelists. So with this, I would like Dr. Umesh Goel sir to go through his presentation. So I am stopping sharing my screen, so you just can kindly share your screen.
Yes, please. So thank you, Dr. Khan, for the nice introduction, and I welcome all the panelists to this important meeting in which we'll be discussing the basics of understanding the constipation and the drug armamentarium, and then the role of the newer drugs and the newer data which has emerged in the past few months. So we all know how the constipation is defined. Constipation is primarily when the patient comes to us, we have to rule out secondary causes like drugs, medications, prior anatomic alterations, prior surgery causing constipation. If when all these are ruled out by proper history taking and by proper investigations, then we label the patient as primary constipation. What and the how to define this primary constipation? We have the Rome 4 criteria in which at least two of the following six symptoms should be present to define this as constipation, and the symptoms should be present for at least 6 months. So this is fewer than three defecations per week, and straining during defecation, lumpy or hard stools, sensation of incomplete evacuation, sensation of inorectal obstruction, and manual maneuvers needed to evacuate. So any two of these symptoms, if they're present, and at least in 25% of defecations, then we label the patient as functional constipation or primary constipation. And the further subdivision of constipation I'll come to in the later slides. So the other data is that around the world, the 15% of the adults have chronic constipation, and it's the sixth most common GI symptom. In the Indian perspective, the study done in the community showed that the prevalence of constipation by Rome 3 or 4 criteria was around 12%. However, the self-perceived constipation, this is a lot of variation. It was up to 53% people in the community felt that they have constipation. 18% had significant staining as stools, and 23 felt they have incomplete evacuation. But overall, 53% did feel that they are constipated. However, only 12% were fit into the Rome 4 criteria. It is more common in females than males, a difference of 20 to 12% in the Indian setup. Another important point is that 6 out of 10, that is 60% patients of constipation, had some comorbidity, that is like diabetes, hypothyroidism, some brain disease, or a combination of these diseases. And almost an equal number, that is 65% patients were older than 60 years. So these two things are very, very important as far as choosing the right drug for constipation is concerned, because we need to choose a drug which is safe in elderly and which is safe in using with these comorbidities, because most of the patients which we will face, like 60 to 70%, will have one of these factors. And in the community survey, they also found that 37% of the patients were regularly taking some drugs which were causing constipation. So that was I was talking that these should be ruled out first by proper history taking, and the first step should be to decrease or stop, if possible, stop those drugs and shift the drugs to a patient to some other drugs which do not cause constipation. That should be the first effort of a clinician. Then constipation does influence the quality of life, very well shown in this study that the all the elements of the quality of life, social functioning, emotional health, mental health, all were very poor in patients who were chronically constipated. And we all know in India that even a Bollywood film was made on this subject, was starring the Big B, who showed the problems and the social and the mental health which person faces who is chronically constipated. So that was very, very nicely depicted in that movie. So which very good, very rightly highlighted the problem in our setup. Then to summarize, other factors which potentially are associated with constipation and which have been found in various studies are again age and gender. We have talked of physical inactivity, self-related health concerns, neurological conditions like multiple sclerosis, Parkinson's disease, depression, GI, cardiovascular, or other conditions like diabetes, prior surgery, or medications like chronic NSAIDs or chronic opium use or aspirin use, and even opium abuse in Punjab, which is so common. So all these factors are related to constipation, and they should be ruled out before start treatment for constipation. So what does the Indian Society of Gastroenterology and the Indian Motility Function Association say regarding the algorithm? So this is the only Indian algorithm available. It says, again, as you highlighted, exclude the drugs and organic causes first by taking a detailed physical history and physical examination. Look for alarm features, very, very important. What are the alarm features for constipation? We all know, but to highlight again, presence of anemia, blood in stools, significant pain, significant weight loss, or a lump in the abdomen. So all these things, if they are present, then we should not wait for investigations. We should get a colonoscopy right away, because there are high chances that a patient has some organic disease. And if the colonoscopy is normal, then we should go to other treatment modalities. Or when the alarm features are absent, that's pretty good. The patient is not anemic, no pain, just having constipation, no weight loss. Then we can empirically start treatment after getting the basic lab test like our random blood sugar, thyroid, and HB. Those should be good enough. So how to choose the therapy initially? So we should take a proper history of the amount of fiber which the patient is already taking. If the patient is not on high fiber diet already and has no significant bloating, then it is good to start with a bulk laxative like isabella husk, which is a soluble fiber. The dietary fiber mostly which we take, wheat bran, other things, they are insoluble and they also cause bloating. Isabella can also cause bloating. So if the patient has no significant bloating and not on high fiber, then yes, to start with, we use bulk laxatives, and we can add with osmotic laxatives like PEG and MOM and lactulose, milk of magnesia, lactitol. All these things can be started as a first line. Combination therapies can be given. While if the patient already has bloating or already is on high fiber diet, then the isabella and other things will not help. Then we should start with osmotic laxatives and simultaneously treat for bloating, look for SIBO and other factors. The patient responds to this treatment well and good. This is the first line treatment. We can give it for even long term, no major concerns, except a few which I'll be discussing later. However, many patients will not respond to this treatment because these treatments are usually mild, and more than 50% people fail to respond to this treatment, and they need a referral to a tertiary care center, which we call as a refractory chronic constipation. So in this patient, we should take a history of, again, review the history. If there is suspicion of a fecal evacuation disorder, how do we suspect this? So we can easily suspect this on history. The patient has history of manual evacuation. It is clear-cut indication that he has a fecal evacuation disorder. Feeling of incomplete feeling of something stuck in the rectum, feeling of a lot of straining. And so this patient will likely to be facing fecal evacuation disorder, while another patient who says that he doesn't feel like the stool reaches his rectum, he doesn't feel that stool is coming down. This might hint us to a slow transit constipation. So if the patient looks to have a fecal evacuation disorder, then we should straight away go for physiological testing. That includes two basic modes of test. One is the CTT study, that is the colonic transit time study, which is a test I'll be detailing in the next few slides. The other is the inorectal uh, function testing. It includes C test as shown here. BET is balloon expulsion test, ERM inorectal manometry, and defibrography is the MR based test. So out of these last three, BET, ERM, defibrography, if two are positive, if we have two, we can perform two. If we have three, we can perform three, because one test sensitivity is poor for diagnosing dyssynergia. So if two out of these three are positive, we label the patient as dysynergic defecation, which has a separate treatment plan. While if the patient has, I have divided the patient to four arms now. We see in the left box, if everything is normal, if the transit time is normal and the balloon and the inorectal testing is normal, then we label the patient as normal transit constipation. And these patients mostly have IBS. So IBS-C, that is called IBS constipation predominant. And the treatment is laxatives and other drugs. While if the patient has abnormal coronary transit time, while normal, no dysynergia, we label the patient as a slow transit constipation. Treatment I'll be discussing later. And if the patient has normal chronic transit time, abnormal test of this we label the patient as fecal evacuation disorder. If all are abnormal, we label the patient as fecal evacuation disorder with slow transit constipation. So with these testing, we can subgroup the patient, and then we can tailor the therapy according to those diagnoses. On the other hand, if the patient does not have anything suggestive of fecal evacuation disorder, we can go to the second and third line drugs, which I'll be discussing in the later slides. So this is the chronic transit time study, which I was talking, done by radiopaque markers. It is a very good study, easy to perform, not very costly, but it is grossly underutilized. So if we see in these X-rays, we have given radiopaque markers to the patient. We give at 0, 12, and 24 hours. And then we get abdominal X-rays at 36 hours and 60 hours, just two X-rays, and after taking radiopaque marker capsules. So now, when we get the X-ray, we divide this by these three lines From the L5 vertebra, we draw the lines to the pelvic outlet and the anterior superior iliac spine. And we divide the abdomen into three regions: the left colonic region, the right colonic, and the rectosigmoid. So now with the distribution of markers, like in this patient, the markers are evenly distributed in the right colon, left, and the
Shamal,
rectosigmoid.
have we dropped Dr. Goyal's voice?
Hello, am I not audible?
Yes, you are audible, sir.
Okay, right. So when we have these three, if the markers are distributed all through the colon, we label the patient as slow transit constipation, as with this patient. However, if the markers are there in the rectosigmoid, we label the patient as a dyssynergic defecation, in which we have to go for biofeedback therapy. While in slow transit constipation, we have a number of drugs which we'll be discussing later. Another example in which the markers are there in the left colon and also in the transverse colon and the rectosigmoid, again, case of slow transit constipation. So when we treat after diagnosing, the treatment aims the primary goal should be relief of symptoms of incomplete elimination of stool and difficult passing stools. Secondary goal is passage of at least 3 times a week as per definition. But in Indian setup, we always feel patients always say that they feel comfortable only when they pass stool daily. The stool should be soft and well formed. And third is that the quality of life should improve. That is the uh, absolute goal, because then patient will feel happy and do his work properly. So what are the current treatment options available to us? Starting with the first line drugs, as we discussed, the bulking agents, soluble and the insoluble fiber, the isabella husk, which we use routinely. So it has a luminal water binding capacity, increases stool volume and softens stool. The possible side effect is bloating. And we all know it's a very mild laxative to start with. In patients with mild constipation, it does help. It has to be taken with a good amount of water, and that might be problematic in few patients in which water is to be given limited amounts. The second line, or even it can be called the first line, are again the osmotic laxatives. They include lactulose, polyethylene glycol, and magnesium sulfate containing compounds like MOM, so milk of magnesia. So they produce an osmotic gradient in the colonic lumen, increase the moisture withdraw water into the cavity and soften the stools. The problem with this that they can also cause bloating, abdominal pain, distension, and some people do face diarrhea with PEG and they have electrode imbalances. The third line available with us are stimulant laxatives, which have been used since long. We know the bisacodyl tablets, the Sena, and the sodium picosulfate. Now, these are the highly abused drugs because these are sold OTC in our country. We all must have seen people taking that green liquid for picosulfate. What do they do? They stimulate the intestinal mucosa to secrete water and electrolytes and accelerate the peristalsis. However, they have significant incidence of causing cramps, diarrhea, pain, melanosis coli, and so these problems do remain. And later on, they lose their efficacy. They first of all they stimulate the colon to increase their migratory motor complex (MMCs), but later on the colon then just cannot move, and that leads to loss of the efficacy of these drugs. The fourth line drugs earlier on, which have now become even second line, are secretagogues. Actually, this first line, second line keeps on changing as the confidence with the drugs increase. So now I must say the stimulant are no longer the third line, and the fourth line mentioned here are easily the third line now. Secretagogues like lubiprostone, which we have been using since many years in India, but we have experienced that it has not very good efficacy. And the new drugs available in this class are lecanatide and linaclotide, which has been recently launched. They increase intestinal fluid secretion and soften the stools, and but they do have GI side effects like nausea, vomiting, and diarrhea. The prokinetics, out of which prucalopride, which is a true pan GI prokinetic, it has action on the colonic motility, does increase the colonic motility, and helps a good number of patients with constipation, but it has problems we'll be discussing later. So these advantages and disadvantages we recently discussed. The only addition in this slide is that MOM compounds can cause hypermagnesemia. They have to be used with caution in elderly and renal insufficiency patients and chronic heart failure patients. Other things we have discussed. And regarding the water and saline laxatives, they are mild, again, cannot be used in cardiovascular disease. Prucalopride has effective with proven safety and I think it has few case reports of QT prolongation. So it has to be used with caution in elderly, especially after 65 years. The dose should be 1 mg, not 2 mg. We have to be very, very careful because of risk of QT prolongation. The longest data available for this drug is 18 months. And the problems which cause headache, diarrhea, and depression, suicidal thoughts are the major concern which the drug has showed, and has to be used with caution in CKD and in patients with who are breastfeeding. It has a high systemic absorption up to 90%. So that is why it is prone to cause systemic side effects, and excretion in urine is up to 65%. So, what are the unmet needs with current treatment options? We know that half of the existing laxatives, half of the patients who are using these laxatives are unsatisfied with the treatment even after using all these drugs. Most of them have just one mechanism of action, so increasing the dose does not help that much. And many of them need more water, and they can cause water retention, and they need more water to take with, which is not possible on patients with comorbidities. Safety in elderly and comorbidities. So problems we have discussed. MOM is unsuitable for CKD patient. Procalopide is excreted by the kidneys. So renal impairment, again, it is to be used with caution because drug levels can rise and cause QT prolongation. And diarrhea happening, suicidal thoughts happening, we have all discussed. So all these drugs have significant problems which we faced, and the long-term compliance may be lost because of the tolerance of these drugs. What do the Indian guidelines say about treating a patient with constipation? So we have two types of approaches as we talk in IBD. In constipation, also we talk of a top-down approach or a step-up approach. So the guidelines say the patients who reach a tertiary care center, especially who reach a gastroenterologist, are already troubled a lot, are suffering from constipation for many years. So that is why a top-down approach may be preferred rather than a step-up approach. So we should give the best possible drug, the safest drug to the patient to gain his confidence, to decrease his symptoms and improve his quality of life. So that is why we should know what new drugs are there and how to use them. A short case study of a recent patient which we did in our treated in our hospital. She was a 45 years old female, chronic constipation since 8 years, with stool frequency of less than 3 bowel movements per week. However, there were no alarm symptoms, no bleeding per rectum, no weight loss. She had a history of diabetes. She was on drugs, and the HbA1c was 7.3, slightly high, although all the other routine tests were normal. Colonoscopy, also done at a previous center 1 year back, was normal, so we did not repeat any blood test or colonoscopy, and we labeled the patient as chronic idiopathic constipation, possibly aggravated by diabetic autonomic neuropathy. So here we then with the drug history, the patient already had done all the possible things which we could think of: high fiber diet, good amount of fluid, taken the commonly available laxative Premafen Plus, which is a combination of MOM and glucosulfate. Then at another center, she had been given procalopide, the highest possible dose, 2 mg per day, but she just had a partial response and a symptom recurred as soon as she stopped these drugs. So we thought of classifying this patient to the various subtypes as we discussed. This patient did not have history of any fecal evacuation disorder, like no manual evacuation, no sense of rectal blockage. So we did not do ARM or manometry or balloon expression test just to save time and money. We went for a colonic transit time study. So this is her picture, X-ray picture. After this, we can see most of the markers are present in the cecum and ascending colon, some markers in the transverse colon, and none and few in the rectosigmoid. So clearly showing that she suffers from a the slow transit constipation. So this might be the first study, I think, on BixiBat showing the real world efficacy by a chronic transit time study. I want to publish this case report and do more patients. So I started her on BixiBat 10 mg before dinner, along with the lifestyle interventions and good glycemic control. Stool frequency locally within 1 week improved to 1 to 2 bowel movements per day, and the Bristol stool form improved. She had feeling of complete evacuation and decrease in bloating. And we did a X-ray repeat. We gave repeat markers, gave BixiBat, and did this X-rays. We see most of the markers have come out. showing clearly how BixiBat improves the colonic motility and how the complete evacuation occurs with this drug. The reason was choosing this is very clear that it's a novel option, and how does it act? We'll discuss later. It has local action. It is known to be safer in diabetes, minimal systemic absorption, better tolerated. So that's why we use this drug as a standalone drug at a dose of 10 mg, and the patient responded. So till now we all are aware of this, but just to reinforce that it has a dual mechanism of action. When the bile acids are not absorbed in the ileum, they reach the colon. There they boost the motility and the secretion, which further enhances bowel movement and leads to complete evacuation. That is the wonder of this drug. And this is a data compiled from all the previous studies done in comorbid patients. We are now basically focused on comorbid and elderly patients because these are the major chunks of the patients suffering. So in diabetes, in renal disease, heart failure, cancer patients, all these show good efficacy and safety. While just in Parkinson's disease, a small study showed that the IDR rates were up to 50%, while the other studies, the adverse event rates were just 5 to 10% on the average, while the efficacy was good in all these diseases. In diabetes, the SBMs rose to 6 per week. The renal disease also around 6 to 7 per week. Heart failure patient 4. So more than 4, we say it's good. So it worked well in all the possible comorbid conditions. Another good things which were showed in a small study with this drug is because it leads to bile acid loss. So more bile acids need to be formed, and they form from sterols, and so that is why the LDL, then the cholesterol formation might become slow. So that is why the LDL levels improved, and also the HbA1c levels improved by 0.2 in this study. However, we need larger data to substantiate this effect of this drug. So there are no head-to-head trials with the drugs with each other. So we have this article which compiled the number required to treat for each drug. So BixiBat, the NNT is 3. That means we need to treat 3 patients to have a good effect for one. And this is higher than almost all the other drugs except for PEG. So lactulose, bisacodyl, lubiprostone, and prucalopride all have higher NNTs. So how can we optimize the use of this drug is that once the patient is symptomatically better with 10 mg, we can continue this drug at 5 mg per day, and given 90 minutes before the heaviest meal of the day, we should give in a diabetes patient like this a glycemic control optimization, maintain high fiber diet and fluid, which should keep on reinforcing these things: adequate hydration, exercise, bowel training, and avoid straining. So this is important that the squatting position in Indian toilets was much better for passing stools because to make the inorectal angle acute. But we have no English toilets, so we can use a foot tool below the feet to raise the feet so that the inorectal angle becomes acute. That is important. We can use this in patients with the constipation. Then this recent study came in which the longest data was 4.5 years of follow-up. And sorry. In this study, it was just a moment. Okay. The study in which followed up for 4.5 years, and the good thing to know, there was no loss of efficacy of this drug for such a long time, even because it acts on one-to-one day basis, acts at the local site. So no expected loss of efficacy. And this study had a lot many patients who have diabetes and kidney diseases. They were all tolerated the drug very well. And the SBM increased by 2.5 per week, and the Bristol stool form increased by 2. All the things were in the favor of good treatment response. And now concern regarding the adverse events were also addressed in this study. The abdominal pain was just 4%, diarrhea 18%, which did not require stoppage of the drug, but reduction of dose led to improvement. And long term, no changes in potassium or chloride level, while minor changes in sodium and calcium levels, which need to be studied in more prospective studies. What really happens to these? LDL cholesterol showed a significant decrease. So this study showed the same finding which the smaller study had shown. and no other major concerns arose from this trial. The phase 3 study, which we had done and already published in the Indian Journal of Gastroenterology, I will not go into details. I will just show that Indian patients responded very well. The weekly SBM frequency was 3.8, and the mean more patients achieved the CSBM, that is complete spontaneous small movements with BixiBat, and more patients with had SBM within 24 hours, and a shorter mean time to SBM than placebo. So the median time for first SBM was 11 hours in our Indian setup, which is very important to time the drug, when to give the drug. The tolerance was very good in Indian patients, with the side effects just 14%, and dry mouth, abdominal distension, pain being the minor side effects. No serious adverse events because it is not absorbed. So that was again ruled out in our study. So to sum up, Alobexibat appears to be a very safe and effective alternative to previous laxatives because it's a locally acting drug, which lactose also is, but it is milder, and picosulfate, we have discussed the problems. Tolerance not reported till 4.5 years, while tolerance does occur with picosulfate and MM compounds. Electrode imbalance, none with alopexibat, well known to occur with most of the other drugs. Safety in elderly, we do not have major data for any other drug, while alopexibat is safe. Diabetic safety, again, we have data with this drug, but not with other drugs. Lactose might not be safe, and other drugs we don't have data. Cardiac safety, prucalopride, we have data, but other drugs no data. So abdominal pain, bloating, all things, no major problem with alopexibat. Suicidal tendencies with the prucalopride have been known. This was just again the comparing the mechanism of action which we have discussed. I think I would like to end here and go to the discussion part. So thank you so much everyone for the patient listening.
Thank you so much, Dr. Goyal, for an insightful presentation. Now we would like to discuss some points. Like, sir, I would like to start from you, sir, Dr. Goyal. So,
Yeah.
what is the current clinical burden of chronic constipation and IBS constipation in your practice? And likewise, we would also like to hear from our esteemed panelists.
So most of the patients of constipation are having functional constipation, which is more common in especially my setting in the Northern Indian setup. IBS patient, which we feel normally they are more of diarrhea or mixed type of picture. Pure IBS-C, maybe if you can say 30% IBS-C and 70% functional constipation, which we see. And I will add on right away that I have tried these drugs because IBS-C patients are also when they are troubled. So I mean, this drug we have data only for functional constipation, and because of pain, initially people used to say that this drug should not be used in IBS-C because it already can cause pain, but the pain incidence is just 10 to 14%. So I personally used in IBS-C patients also because I feel the pain in them is because they're not emptying out their bowel. That was the reason of pain, or and the visceral hypersensitivity, of course. So I mean, we have the data. We are doing a prospective trial, and I have found that it is quite safe and effective in IBS-C also, and did not have significant problem of pain. So I mean, this could be a good drug choice in IBS-C also.
Okay. So, usage of alopexibat was done at the dose of 10 milligrams in such patients.
Yeah, I usually decided depending on the previous drug history of the patient. The patient now have started using as a first line also. In the patients who have not received prucalopride or ibuprofen, the third line drugs, they have just received osmotic or bulk laxative, which almost everyone has received. In those, I start with 5 mg and see the response. If doesn't respond, I build up the dose in 1 week or 5 to 7 days. The patients who already have received, we have to start with 10 mg, of course, because we know they are already having resistant constipation, and 15 mg rarely I needed to go.
Okay. So in IBS-C patients, do you see a reduction in the drugs which are usually utilized for decreasing the abdominal pain other than the usage of drugs for chronic constipation or IBS-C management constipation component?
Yeah.
So is there a
So
decrease in the usage?
yes, I cannot say that exactly because I have not reduced till now. I've been started using in IBS since the last maybe 2.5 months. So I have not withdrawn drugs till now. Like we normally have to give mebavirin clode as a buckshot combination to them because of pain and visceral hypersensitivity. So I would like to do in future, but I have no experience till now because I really fear that at least the constipation is settled, and this medicine we will withdraw in a later when the patient has confidence on the drug and the patient is okay. I think yes, the drugs can be withdrawn, can be reduced or withdrawn definitely, because as I said, when the patient is emptying the bowels, the abdominal load is decreasing, patient might be able to reduce the doses.
Okay. Thank you so much, sir, for your viewpoint. I would also request Dr. Prerna Goyal. Ma'am, can you hear me? Ma'am, we would
Yes.
like to know from you your viewpoint, like what is the current clinical burden in your practice of chronic constipation as well as IBS patients?
A very good evening to everyone. Thank you, Team Redis, and thank you, Dr. Bushra, for having me among the esteemed panel of expert gastroenterologists. And in fact, it was a very insightful session for me also, because managing a patient of chronic constipation is a major challenge in our clinical practice. And as far as prevalence of the constipation is concerned in our clinical practice, because I'm not a gastroenterologist, I don't see much of IBS patients as alone, but most of the constipation patients, they are as a part of the spectrum of the patients having a comorbid conditions. Mostly these are the diabetic patients, patients who are having comorbidities, elderly patients, patients with the heart problems and the kidney problems. And majority of these patients, they are on multiple medications, polypharmacy, which may be contributing to the constipation also, because many diabetic patients, they have autonomic neuropathies. They are on pre-gaps and other kind of the neuropathic treatments also, and that may be the contributing factors for the constipation. And I think in my practice, it is mostly the comorbidities and the polypharmacy which is contributing to the constipation.
Okay. Ma'am, do you have any experience of usage of BixiBat in such patients who
Yeah,
come to you?
yeah, because of Dr. Mesh only, I get to know about these drugs. And Alopecia I started using 2 to 3 months back, and my experience was quite good. Initially, I used it as an add-on therapy for the constipation, medication refractory constipation patients who are not improving with the other therapies. And there is always concern about the liquid formulations, which only use as a part of the constipation treatment. Many patients, they are reluctant to take the liquid formulations. They have preference for the oral tablets. So in that way, Alopecia is an edge over the other constipation medications. As my experience improved and good efficacy with the Alopecia in the chronic constipation management, so from as an add-on therapy, I have started using it as a sole agent. In fact, my first choice is still the bulk laxatives. And if the patient is not improving, I have started using Veloxibad as a second line agent in our practice, my practice. And the outcomes are very good. I must say that majority of my patients are cardiac patients having kidney problems and having like stage 3 and stage 2 and stage 4 CKD. They have a good tolerability with Veloxibad because there is a major concern while starting these medications, for especially a cardiac patient. We have to be very, very cautious about the use of prokinetic agents like prucalopride, and because there is also concerns about the cardiac safety and renal safety of these agents. And now we have another molecule in our armamentarium, especially in the diabetics and obesity treatment, that is GLP-1 analogs. GLP-1 analogs, they cause constipation because they have action on the intestine and the local action, and the constipation is a concern with these molecules. So in all these wider spectrum of the patient, Alopecia is definitely giving a good results with a good safety profile, I must say.
So, I mean, Dr. Prerna, yes, yeah, I don't have experience in using GLP-1 analogs. People now, you treat so many obese patients and diabetic patients. So, I mean, so do you mean the constipation will increase? I mean, the problem of this will increase because of these drugs. GLP-1 analogs, now people want the weight loss, quick weight loss with these drugs, and they cause gastric slowing, we know that, and they do cause constipation. So I think then with the advent of use of these drugs, the problem of constipation is going to increase. Huh?
Yes, they slow the gastric emptying, and they because of that mechanism, particular mechanism of the action, It can cause constipation, and that has been reported in the literature also. As far as a direct causal relation of GLP-1 constipation has not been defined in practice because these molecules are very new. Maybe in the later months or in the later time, we'll be able to get it more data whether these agents are really causing constipation, or because only seeing the trend whether the patient is developing constipation after starting these drugs, or was the per se
Yeah.
constipation that has worsened. So it is because of the new molecule we have these kind of the side effects, adverse effect profile, which is new to us also. But I think Elobixibat has made our treatment less challenging now because this molecule is very easy to save, easy to use in clinical practice.
But this molecule also called a small tussle in our home. I remember 2.5 months back when she came, she said, "Okay, what is the trade of this new drug?" I said, "BixiBat." She said, "No, it's Bixify." I said, "No, it's BixiBat." So we literally for 5 minutes, I said, "Oh, how can I be wrong? I've been writing BixiBat." Then we came to the DRLS two branches. One is for gastroenterologists and one is for physicians. So she
Yeah.
was being promoted with Bixify, and I knew only of BixiBat. Then I came to know that both are same.
Because nowadays so many drugs has been added in the art field, no?
Hmm.
Like diabetic agents, and there are so many other medications also. And I used to hear from him only that the constipation, that lubiprostone. Now we have another molecule. Now another molecule. It's very difficult to remember and register those names. So when he introduced me Bixify, I registered in my mind that it's Bixify. So that was that. So that was the day when I remembered by the name that it's Bixify only.
Thank you so much, ma'am, for such an elaborate response to my query. Thank you so much. Now, we would also like to hear from Dr. Rajdeep Singh. Sir, can you tell us about your experience with the drug in your patients, and what are your usual first line treatments in both these conditions?
Hello, am I audible?
Yeah.
Yeah, sir.
Yeah. I've been using this molecule from last 3-4 months now as a second line after bulk laxatives and as a second line therapy with the monotherapy also and also in combination. So approximately 50% of the patients have been they are satisfied with this drug along with some bulk forming agents if they are not having that good diet. But 50% of patients have not shown a good response. So I've increased the dose to 15 mg and yet to see the response. 10 mg, approximately 40 to 50, did not show much, very good response as I was expecting. But the rest, but it's very safe, absolutely safe. So it's not getting absorbed at all, not excreted through the kidneys. So absolutely safe, especially where this is it's a good molecule for patients with comorbid conditions, as Dr. Amish nicely told us about. So really, I'm really looking forward to using this drug, but I've yet to see my own personal response.
Okay, sir. Thank you so much. Dr. Manjeet Goel, can we have your viewpoint about the usage of the drug in your practice?
First of all, I
And what
would
are the
like to
advantages that you see over the other drugs?
first of all, I would like to thank Dr. Reddy's for this great initiative and Dr. Umesh Goel for inviting me and giving me an opportunity to be a part of this wonderful talk. Dr. Umesh Goel sir has been my professor during my GI fellowship times, and he has been a great mentor. And sir has beautifully summarized about the various management options of constipation. And sir introduced me to this molecule. We had this talk around 6 months ago, and I started using it in my daily practice. At least around 30 to 40 patients of mine are on Elobixibat, and in around out of those around 20 patients, I'm able to step down the dose from 10 mg to 5 mg, whereas around 5 to 6 patients, I had to step up the dose to 10 from 10 to 15 milligram, but the response is very good. Especially the major advantage is it starts working from the day one itself. Like there is not lag, like the peak response will come later on. Like the patients, they come to us when they are already troubled. They have gone to 2 or 3 physicians or some local doctors, and they have now already exhausted all their whatever the patients is already exhausted, and their funds are also on the verge of getting exhausted. So they want a quick relief. So this is a quick remedy and an effective remedy. So it is doing wonders. And why I'm yet to like there's always a question in my mind, like if somebody doesn't respond respond to BixiBat? And what should I think about going back to prucalopride, or should I go back to Lubovil, or should I add on? So that is something I think we need to more
Maybe
data
Dr.
So
Goel,
Helix
sir.
is
in
solving that
future
problem also.
will
They
have
are
more
going to launch liraglutide.
clarity on this topic.
So Manjeet,
Yeah.
we will have more drugs
Okay.
now. So liraglutide is being, I think, when is it is being launched, Dr. Khan?
So it
Soon?
is expected to be launched around July end.
Yeah. So I
Oh,
mean
in a
that
month
would
time.
be a good add-on, drug. That would be good add-on drug. But let's see the efficacy in our population, because lubiprostone has a miserable efficacy, I must say. I mean, just response comes in just around 15 to 20% patients. So with the seritagogues, but this drug has a slightly different action. So let's hope that I think it could be a good add-on drug. I don't hope that would be a standalone drug. Like BixiBat is a good standalone drug in such a good number of patients, which we all have experienced. And that the secretagogues could be a good add-on drugs. Dr. Bhupinder.
And also, sir, I
Dr.
feel like
Bhupinder, we would like to hear from you also, sir.
Hello, good evening, everyone. First of all, am I audible?
Good evening, sir.
Yes, yes.
Yeah, sir.
Yeah. Hello to everyone. First of all, I would like to thank Dr. Reddy's, Dr. Umesh for considering and making me part of this study and the academic oriented, because being in private practice, it is always when you are alone. I always wished to be part of some research or some part of some kind of study, so that to just get a feel of the academics as well, because this part has been always ignored till now. But Dr. Umesh has been a good friend, a senior guide, and he has helped me in considering to be part of this study. And while we were discussing in the last meeting, which happened a few months back, since then we have increased the use of BixiBat and BixiBat. But the experience in our setup has been like, we'll have been able to use this molecule in patients who have been refractory to the first line of drugs as an add-on therapy, and in patients who have had milder form of constipation, and getting decent results. But as a single molecule, as a standalone molecule, this has not been shown to be really performing that well. But as an add-on therapy and in refractory cases, it has shown good promising results, especially considering those patients which are high risk for cardiac and renal dysfunction. We have been able to use it safely. And as far as another point is that it is available in the form of tablet, so it makes the things for the patient easier to consume, and compliance is better. And patient always look for something new to which is not available in routine practice. So that is our experience till now.
Okay.
Yeah,
So what
maybe
is your
Dr. Bhupinder,
preferred?
you, yeah, sorry to interrupt. Maybe you have used it, or as you said, only in refractory cases. Now, I would suggest to try using it as a second line therapy. You will feel much better results. The patients who have failed osmotic and bulk laxatives, they come to you. If you try using that, even you will see that 5 mg dose is working, and the patients can do well just with 5 mg alopecia. Just try and now those patients. It really happens. I also initially used in refractory cases, but when you use the molecule, you get confidence in the molecule, and then you start using in uh, primary or I mean second line as a second line therapy. It will work there also.
Right.
May I speak?
Yes, Dr. Khan. Yeah.
So, Dr. Bhupinder, what is the ideal time of administration of this drug? Like, are you using it before breakfast or before dinner?
Before breakfast.
Okay. Dr.
Yes.
Umesh Goel, sir, can you guide us on the timing of administration? What
I
is the
would like
ideal?
to, yeah, I mean, this is because the Japanese studies mostly they tell us to they use before breakfast, But in the Indian setup, what we all have been trained that we have to pass stool in the morning, and in the daytime we feel very awkward. So I mean, as the time of first SBM shown in our trial, Indian trial was around 10 to 11 hours. So I have been using it before dinner, and patients are happy with the timings. They get up in the morning after. So if you take at around 8 p.m. and 7 a.m. or 6 a.m. in the morning, you have the urge and patients do pass stools. So only just one or two odd patients told that they had to get up midnight for because that is also it happened in the initial few days of this drug. Initial 1 to 2 days, patients do have some crampy pain or few patients may have some diarrhea, but most of the patients are satisfied by using it before dinner. And the number two thing, we have to use it before a major meal of the day because it inhibits the bile acid absorption. Then bile acids has to go to the colon. So if the patient is not having suppose dinner and we give this drug, it will wastage of the drug because the drug will go there, block the receptors, but there are no bile acids there in the colon, in the small gut, which will go to the colon. So we time it before the meals so that suppose we give it 90 minutes before the meal. So the drug has already reached its site of action. Patient takes a meal, bile acids come in the small gut, bile acids reach there, they don't get absorbed, they reach the colon. So these two things have to be kept in mind that it has to be given before the major meal, then only it will act. And number two, timings, yes, it can vary from personal choices before dinner or before breakfast.
Okay, thank you, sir. So one of the important questions that we usually face in our interactions with doctors is whenever we are combining BixiBat with one of the other drugs which are used for the treatment of chronic constipation. So while we are using both drugs simultaneously, so after a certain point, if you want to reduce the doses of other drugs which are being given along with BixiBat, so what should be the ideal way, and after how many weeks can we expect the response to be so good that we are able to reduce the doses of other drugs?
No, it's really not difficult because this drug starts showing us action within 1 day only. And when the patient comes to, actually, I initially in resistant cases, I just write them the second drug, the laxative, a combination laxative which we have in the market or a bisacodyl tablet. I write them as a rescue therapy. I tell them so that the patients need not come back to us again and again. I write BixiBat and I write any syrup or Dulcoflex, bisacodyl tablet as a rescue therapy. Tell them if you don't pass stool after 2 to 3 days of BixiBat, and then you can take this as a rescue therapy. And this has also worked very well in resistant constipation patients. So you have to give them some rescue therapy. You don't want patient because this is a new drug for them, new drug for us. Suppose maybe it doesn't work in 20-30% patients. Yes, we know that. Suppose it doesn't work, the patient will be so troubled that, oh, what drug doctor has given me? I am not passing able to pass tools, then he will run here and there. So better to give a rescue therapy on the paper that okay, if you don't feel comfortable, you take this drug on third day, fourth day, and with this the patients are happier. Then when the patient comes back, you ask them, okay, what happened? The patient says, okay, I needed this just twice or thrice, or even some patients say I needed it daily. In those, you can step up the dose to 15 mg of BixiBat, or you want to add prucalopride. This is depending on the patient profile.
So another thing is in your practice, whoever has used the BixiBat since at least 3-4 months, so was there any incidence of side effects like diarrhea or abdominal pain in significant number of patients
Not at
that
all.
were being given?
I really feel it was even less than the what happened in trial. Diarrhea and pain trial which we did in Indian setting also, the pain was up to 14%, diarrhea was 4%. So I think pain was pretty less. Maybe it was just 2 to 3%, and again diarrhea was also similarly so less. So I mean, I'm really surprised. I also thought pain would. That's why I started using an IBS-C. So after 3 months of usage, when I found that pain is so less, then why not use an IBS-C? So that builded my confidence, and IBS-C patients also do not have so much of pain. Maybe
So
because
regarding the
maybe this may be because I start with 5 mg dose in patients who are moderately constipated. Maybe this is the reason because in trial we started with 10 mg. So I usually start with 5 mg in patients who are as second line therapy or who are moderate constipation. So maybe and gradually build up the next week. Maybe this had helped.
okay. So as the mechanism of action of this drug is very unique because it is dual prosecretory as well as pro-motility. So do we get any advantage in terms of clinical impact of this particular dual mechanism? Like if we compare it with prucalopride, which has got only promotility effect. So do we see, a difference in the efficacy clinically?
We can say because it is working in patients who were refractory to prucalopride, so that shows that it might be more efficacious. So obviously we do not have any head-to-head trials till now, but we are taking this real-world data. We have not compiled the data with the multicentric data of using. We are taking into account the patient symptom profile, the quality of life, so many factors. And we have two subgroups of patients. In one, we treatment naive patients. We are using these two drugs, and number two, refractory cases, patients who are refractory to prucalopride, we are using this drug. And the way it is helping those refractory patients, it clearly shows that their dual mechanism is leading to a good impact.
Okay. Thank you, sir. From the esteemed panelist, if I can get your experience on the comparison of these two molecules, like what was the impact in the clinical practice after using prucalopride and BixiBat in separate patients? Do you see a difference in the clinical efficacy or in the incidence of side effects? Because the reported side effects with prucalopride are very frequently, I've come across this point, like dizziness and headaches are very frequent complaints with the usage of prucalopride. So do you see any advantage in terms of compliance of the patients with BixiBat over prucalopride? Dr. Rajdeep, Dr. Prerna, Dr. Bhupender, and Dr. Manjeet Goyal, sir.
Yes, I think with prucalopride, the efficacy seems to be a bit better, but obviously the side effects are also quite frequent. And many patients, we have to discontinue the drug because of the side effect. So efficacy comes with some added side effects, I think, which were quite frequently noticed, and quite frequently we have to stop the drug. As far as BixiBat is concerned, BixiBat is concerned, so the side effects seemingly are very, very infrequent. But as far as the efficacy is concerned, we have to, as we discussed, so it has to be like an add-on therapy, or and in milder form of constipation, it can work as a standalone drug. So that is our experience.
Thank you, sir. And sir, as we know that BixiBat has got a local action, it is not systemically absorbed. So we do
Right.
not see many side effects, and it is also very safe to be used along with so many other drugs and in patients with so many comorbidities like cardiac, renal comorbidities, as well as it has been safely given in cancer patients, in Parkinson's disease patients.
Yes.
One of the very frequently asked query
I
about this
think
drug is
I think the considering whatever little experience we have had till now, and sharing all the knowledge whatever we have gained from other fellow colleagues, it just comes to my mind that we have to use it very judiciously, and specify in specific situations where to get the optimal results. Those specifications and those indications are just getting clearer to our mind as we are using the drug. So I think in couple of months we'll just be able to get which patient will be able to get good results. So I think we can use them in a better way.
yes, sir. And so because of the local action, we do not see many side effects as well as its safe usage in various comorbidities. So one of the queries that we very frequently come across, Dr. Goel, is
Yes.
the usage of BixiBat in patients who are having liver disease. So there is a study done by Nakajima et al. And it was published in 2025, very recently.
Yeah.
So they have included approximately 3,600 patients in the trial, and their follow-up durations were 1 year, and some patients were also followed up till more than 1 year. So there were various patients who were having comorbidities who were included in the trial. So liver disease patients as well as biliary disorders, they were also included. So approximately 111 patients, approximately 4% of the total patients, they were having liver diseases. And when the data was analyzed and the results were seen, the safety analysis showed that there was no effects on the liver. Like there were no liver safety issues in the overall subset that was analyzed. So that is one supportive data that we have with us that
Correct.
shows that in the liver disease patients, there was no undue increase in the levels of the enzymes.
Yeah, because before the publication of this article, we all were skeptical in using this drug in liver disease patients because of the bile salt loss. Now, this study showed this, 111 patients and no worsening of liver enzymes was there and no worsening liver dysfunction. Although the patients with liver disease were in childhood A and B class, obviously childhood C class are highly advanced liver disease patient. No one would use in that class. So this study, yes, to some extent, it has solved our problem that this drug can also be used safely in liver disease patients. Although we would like to have more data on this subject because the bile acid metabolism is really a part of the liver disease, and they already that is hampered in CLD patients, but definitely in child A and early child B, I have used in just one or two patients till now in the last few days. So we can start using this drug. The concerns will slowly go away. Again, as we use, we see the patient improving, our confidence will build up, and the concerns will go away.
Dr. Manjeet Goyal, can we have your viewpoint on the same?
I think Dr. Manjeet had to board a flight. Today he's traveling to US. He might.
Yes, sir. I was preoccupied. I apologize. Yeah. So my experience with the BixiBat is what is I think the question right now. It has been pretty good, and I just wish to see more of it on the other side as I'm traveling to United States for next 2 years. So I'll see there what is their experience and what is the thing that they feel about it, and maybe bring back that new aspect or new perspective from there, and then hopefully we'll do wonders here.
Dr. Manjeet, I'll be connecting with you regarding the experience of linaclotide that you may gain there because we are soon to launch that.
Sure, definitely.
We'll be launching that in US right away. India and US.
That's already established there.
Yes.
It's FDA approved. Yeah. So we will be launching it across 7 countries.
Okay.
So India being one of them. Yeah.
So I've already planned with Dr. Manjeet that for a multi-centric, multi-country data. So on many subjects. So this will be another focus subject. We will have data on the linaclotide in US patients and Indian patients. That's a good new idea.
Sir, one thing that came to my mind was like there is an opioid-induced constipation, which is a very prominent thing especially in north of India. We don't have a specific data about Ilobixibet.
For any drug, we don't have data on that.
Yes. So I feel like for opioid-induced constipation, which we face every day, the basic is like whatever the gastroenterologist has seen is or her clinical experience. That is the drug they follow.
So, in the real world study which we are doing, we do have patients, we are enrolling patients with OIC also. We can do a subgroup analysis and see, I mean, what they might be requiring higher doses or some other. We will do a subgroup analysis in this study.
Dr. Prerna, can we have your viewpoint regarding the same? Dr. Prerna?
Yeah. I think every insight has been shared by all the esteemed panelists, and data is very new to many of us. I think in the couple of months, when we have more and more experience with this drug, we'll be able to give more insights about the safety and efficacy of this molecule in our patients, in our Indian patients especially. I have one query. What is the drug of choice for the management of constipation in pregnant patients, in pregnant females?
Very good and question because it is important thing we for drugs in pregnancy. So we don't have safety data for most of the drugs. BixiBat in children pregnancy, no data. Propylene, no data. So we do for this lactulose is safe, but it does cause bloating and cause other problems. But this is the only safe drug, and MOM compounds and lactulose can be used in pregnancy.
They are safe to use.
Yeah.
And so regarding the use of BixiBat in chronic constipation, we have discussed much in detail about the usage. And one very good upcoming thing about the molecule is at some institutes, this drug is also being tried now for the treatment of intrahepatic cholestasis and in cases of obstructive jaundice. So the discussions are still going on because in a chunk of at least 30-40 patients, at one of the primary institutes at Delhi, Hepato Institute.
Okay.
So they have tried, the doctors have tried and got good results in the decreasing the serum bile acid levels clinically. The results have been obtained. Serum bile acid level assessments and all will be taken up later on when some study will be planned. So all these discussions are going on. So that's something new about the drug.
That is a good idea which they are doing. I mean, it could really help those patients who are so
Because
troubled.
there is no data as of now regarding the decrease in the level of hepatic and decrease in the level of serum bile acid levels with the usage of BixiBat in patients who are cirrhotic. Although we do have data on the healthy subjects, like what will be the effect of BixiBat on the serum bile acid levels, there is a small, data on a small number of patients, which was published in 2022 by Nakajima et al. So they have measured the serum bile acid levels as well as the fecal bile acid levels. But we do not have any data on the cirrhotic patients as of now. So these are the areas of discussion,
So they
ongoing
used
discussions.
in patients without constipation?
They have used in patients with constipation as an indication, and for the hepatic indications individually they have used. So in chronic constipation, we have got many feedbacks from across India. But in the liver patients, people were initially hesitant to use. But from the ILBS, we are getting this feedback from the top hepatos. So the discussions are still ongoing. So in the times to come, we can have research coming up and publications coming up on this. So with this, Dr. Umesh Goyal, sir, I would like to request you to give your closing remarks, and thank you so much, everyone, for contributing to this discussion. Sir.
I would like to just end by saying this, that yes, we have to treat this problem very wisely, starting from listening to the patient properly, listening to all the problems, the stool frequency, the stool form, because I didn't discuss this today, but when a resident takes a history quickly, he says, oh, sir, patient has come with diarrhea. He says he's go to passing stools 5 times a day. And when you review the history, the patient says, I go to the toilet 5 times, but I pass hard stools and I feel incomplete evacuation. So starting from a good history taking, drug history, rooting or secondary causes, then start using the first line drugs and see the patient, what drugs patient has received for constipation, and then use wisely according to the comorbidities and the age and other factors which drug to use. And then you can have your own combinations of decreasing or increasing the drug levels. And so that we have to provide a holistic care to the patient to improve his quality of life, to improve his lifestyle, so that he does his normal work with ease. So this is the role of a physician, to do a holistic, to provide a holistic care to the patient and improve his lifestyle.
Thank you so much, Dr. Goyal. And on behalf of Dr. Reddy's, I would like to thank you all, Dr. Rajdeep sir, Dr. Bhupender, Dr. Prerna ma'am, and Dr. Umesh Goyal for your time as well as your contribution in the discussion related to the management of constipation and IBS-C. So I'm really grateful that you all of you gave us your precious time and your contribution. Thank you so much.
Okay,
Thank you. Thank you so much.
Thank you, Dr. Umesh. Thank you so much. Thank you, everybody.
Thank you, everyone.
Bye.
Good night.
All right.
Bye, Dr.